I am Joao De Quevedo. I am professor here at UT Health Houston, Department of Psychiatry, where I direct the treatment-resistant depression program. So, as you know, depression is a very important issue in the American society. It's costly. It takes days of life of a lot of people. And unfortunately, despite the best treatments that we have, not all patients improve. So 1 in each 3 patients have what we call treatment-resistant depression. What means that despite taking the medications, despite seeing a therapist, they still do not improve to the full extent of what we want. For these patients that we developed the treatment-resistant depression program here at UT Health. Patients with depression, usually they seek first care with their primary care physicians, and if the approach, usually at least 2 different antidepressants, do not work, the primary care physicians usually refer these patients to psychiatrists. And the psychiatrists would try another strategies, might add psychotherapy, might do some pharmacological augmentations, and for most of the patients it does work, but still for some it does not work. These are the patients that come to see us, patients that despite the best care regarding medication and psychotherapy, they are still not improving. What we do here, we do a first assessment where we go over the patient's history, all the medications already used, we go over all the therapies, all the non-pharmacological interventions, and we try to first confirm that the patient has depression. Second, check if this depression is unipolar or is bipolar depression, because it changes a lot the treatment strategy. And at the end, together with the patient and with the referring psychiatrist, we build a treatment plan that might include adjustments on the medication, might include more advanced psychotherapy, and lastly, most of the times, it includes some modality of interventional psychiatry. These interventional psychiatry modalities, they range from much less invasive strategies, like Spravato, that's the intranasal esketamine, or the intravenous ketamine, going through transcranial magnetic stimulation, also known as TMS, or the electroconvulsive therapy, also known as ECT. Even when these approaches still do not work, we can go even further with what we call invasive treatment modalities, where we have 2. One is the vagus nerve stimulation, where we implant a kind of pacemaker surgically, and this pacemaker is linked through a wire to the vagus nerve in the patient's neck. Or even deeper, when again we have a pacemaker, however this is linked to electrodes placed in the patient's brain through wires that goes under the patient's skin. So we are very proud of having a very wide portfolio of intervention strategies, and we do believe that one of them should best fit our patients' need. What I always say to the patients that come to here, we never give up. So when we see patients here at our UT Health Houston treatment-resistant depression program, we make sure that we have the right diagnosis, because the depression might be either unipolar or bipolar. Once we find a right diagnosis, the next step is to build up a therapeutical plan. And I usually use this whiteboard to discuss with the patients what we are thinking. But basically, our strategy encompasses pharmacogenomics guided psychopharmacology, what means that we do pharmacogenetics tests for all our patients, psychotherapy, and the interventional psychiatry. Here in the pharmacogenomics guided psychopharmacology is that is very important, the definition, if you are talking about unipolar or bipolar depression, because the strategies change. For the unipolar depression, we try first to do what we call augmentation, is to using some pharmacological agents to make the antidepressants work better. Some options that we have here: lithium, T3, and several atypical antipsychotics, all that are we have some evidence that work for unipolar depression. Or we might combine antidepressants, we might use the old-fashioned but is still very good tricyclicals and the monoamine oxidase inhibitors. If you are talking about bipolar disorder, in the case bipolar depression, we have also a plenty of different options to be used. Regarding the interventional psychiatry, we always go from the less invasive to the more invasive. The less invasive approach is the TMS, transcranial magnetic stimulation, and then we also have a bit more invasive, the intranasal esketamine or the intravenous ketamine, and then the electroconvulsive therapy. ECT has been around for almost 100 years. It is still a very powerful therapeutic tool. If these options still do not work, we can go to more invasive options like the vagus nerve stimulation and the deeper brain stimulation. But we like to have a more comprehensive approach and discuss this with patients. It's very cool because a lot of patients, they take pictures of this whiteboard because they want to share with family and friends to better understand what's the game plan that we have built together.